Good evening, everyone, and welcome to the PSPS training webinar series, session 2, the treatment of sacroiliac joint disease. We are so excited you have joined us this evening. The webinar will begin in just 2 minutes to allow a few more people time to log on. Again, thank you for joining this evening, and we will begin promptly at 9:02. Good evening, everyone, and welcome to the Pacific Spine and Pain Society training webinar series. This is session 2, focusing on the treatment of sacroiliac joint disease. We are so excited you have joined us this evening, and we will start the webinar promptly in 1 minute to allow a few more people time to join the webinar with us. Again, thank you for joining us. We will begin promptly at 9:02, or 6:02 in Pacific time, pardon me. Good evening, everyone, and welcome to the Pacific Spine and Pain Society training webinar series. This is session 2, focusing on the treatment of sacroiliac joint disease. We are so excited you have joined us this evening. We will begin promptly in just a few more moments to allow a few more people time to join us. Again, thank you for joining us this evening. We'll begin promptly at 6:02. Welcome, everyone, and thank you so much for joining the Pacific Spine and Pain Society's training webinar series. This is session 2, treatment of sacroiliac joint disease. Gentlemen and ladies, take it away.
Good evening and welcome. On behalf of Pacific Spine and Pain Society, thank you for joining us tonight. This is a really exciting session that we have planned for you tonight. I'm Jessica Jameson. I'm an interventional pain physician in Coeur d'Alene, Idaho, and I will be your moderator for this evening. And it is my distinct pleasure to keep all of these lovely gentlemen in line for the next hour to hour and a half. With that said, let's move on to our learning objectives here. Tonight, we're going to describe the basics and some of the advances in the technology for sacroiliac joint treatment. And we are going to discuss many different aspects of this, but I think some of the most important and exciting part will be the videos that you'll see on how to actually perform sacroiliac joint fusions. That's something that has changed significantly over the course of the last few years, and is something that we've added to our arsenal that we haven't had before, and many of us may not be as familiar with. So we've got an excellent lineup of panelists who are going to go through some of the ins and outs of sacroiliac joint diagnosis, of the examination, and then we'll move into some of the videos that will show us how to perform these procedures. So the agenda for tonight, Dr. Lee will discuss the diagnosis of sacroiliac joint disease and our current treatment options. And then we'll move on to Dr. Patterson, who will talk about the posterior approach sacroiliac joint fusions. And then we'll move on to Dr. O, who will talk to us a little bit about the lateral approach for sacroiliac joint fusion, which is something that is very important and a lot of us don't know much about as well. And then we'll move into our videos, and those videos will be broken down into 3 separate videos where we'll talk about different types of posterior approaches to the sacroiliac joint fusion. And then we'll end with a roundtable with all of our faculty answering questions from our audience tonight. Next slide. With that, I'm going to turn it over to Dr. Lee. Dr. Lee is a double board certified in physical medicine and pain management, and he practices at St. Charles Spine in Thousand Oaks, California. He's also the president of the Pacific Spine and Pain Society and plays key leadership roles in many of our pain societies throughout this country. Dr. Lee, take it away.
Great. Thank you so much for having me. I see those disclosures are on the slides now. Nothing specific to this talk per se. And so, I'd like to start off, if you go ahead and next slide, talk about the sacroiliac joint as a whole. We're going to talk a little bit about the pathology, a little bit about its prevalence, ways to kind of really fine tune how do you figure out if the sacroiliac joint is a culprit, and that involves physical exam and a little discussion on imaging. And then, our current conservative treatments that we do a lot of, such as physical therapy, oral medications, a little discussion about intra-articular joint injections, as well as lateral branch blocks and potentially radiofrequency ablation. And then as that algorithm progresses, what do you do next in the surgical intervention? And I know that's what's exciting a lot of people on this webinar tonight. And we're very lucky to have an amazing panel, headed by Dr. Jameson and our colleagues that are going to discuss about multiple systems for posterior approach, as well as the surgical lateral approach and where the future is going. So I'm excited to be a part of this. Next slide. So the first thing when you think about sacroiliac joint is you have to admit and recognize it's a major component. Pretty much everybody in the field of interventional pain or spinal surgery, and pain psychologists and all different backgrounds of neurologists know back pain is a huge predominant factor in many of the patients we treat, and probably the #1 complaint they have. And you have to kind of think about the sacroiliac joint as being a significant component of that back pain. Oftentimes, historically, it's been something that's thought of as an afterthought. But unless you start thinking about the SI joint as a pain generator itself in your algorithm, you could really miss a lot of opportunity to help improve your patients' lives. First of all, a lot of times the lower back pain for a sacroiliac joint is common to be slightly lateral to midline, but that's not always the case. I mean, you think about all of our cases, a lot of times everybody's familiar with thinking of the L4 or the L5 facet, or L4, L5 radiculopathies or L5S1 areas. But the sacroiliac joint is the next joint immediately adjacent to those levels. So many people who have back pain, it's estimated that about anywhere from 15 to 30% who have low back pain also have sacroiliac joint pain. Now, it's not something that's necessarily in isolation. Oftentimes, it's something that happens in synergy with multiple levels. And so it's a weight-bearing joint. And a lot of times with mobility issues, as there's natural wear and tear and degenerative disc disease in the lower levels from L4 and L5 and L3, the sacroiliac joint also has wear and tear as well, because it starts out as a synovial joint and gets compressed over time. When you consider those factors, it's not unreasonable at all. It's a little naive, actually, to think that the sacroiliac joint isn't involved in a large percentage of people with low back pain. And you think about now post-surgical back pain, specifically fusions. Our colleague, Dr. O, will talk a little bit about different surgical aspects when he's looking at sacroiliac joints. But oftentimes, if you fuse levels, and one of the most common levels fused is L4-5 or L5S1 or even L3-4, all that stress is then transmitted to the joints above and below that fusion, because all those facets that normally give a few degrees here and there and a few millimeters here and there don't. So that force gets transmitted, directly below or above, and with more weight bearing below, that often then is transmitted down to the sacroiliac joint. And oftentimes these patients, when they start out, probably had some component of sacroiliac joint pain. However, the epicenter of their pain was diagnosed at the L4, L5 region. That area was treated. So now after the fusions, and they still have ongoing back pain, you have to think about the sacroiliac joint pain, which has been estimated up to as high as 61%. So with that, next slide. And so when you think about the sacroiliac joint, it's kind of important to take a step back and think a little bit about the anatomy. As I mentioned before, it's a synovial joint, which means initially when you start, the joint has a little bit of space there and has a little bit of fluid. It's not a ton of space. It's not as large as your knees, for example, or other joints, but it is present. And as time goes on, degeneration, wear and tear, and gravitational forces kind of load up and shrink that space there, and some of that synovial fluid kind of dries up. It's a weight-bearing joint, so it's the primary weight-bearing juncture between your lower extremities and your upper extremities and your axial skeleton. And it has a very complex innervation pattern. And that's important to think of. And so what I wanted to highlight on this slide is that there's a web-like posterior capsule, and that's comprised of multiple ligaments. Now, in that mesh, or those ligaments, is a three-dimensional structure. Nerves can go in a wide variety of areas. And the key is, where do those nerves go? And those nerves go anywhere from the anterior part to the sacral table, medially to the sacral foramen, and then posterior and laterally through these ligaments. And they kind of branch out in a web-like distribution. And the reason that's important to understand is that capsule is kind of posterior part of that joint. So a lot of times when we're looking at our patients and we're looking at the sacroiliac joint and you're trying to decide of what kind of treatment option you're doing, if you're doing an intra-articular injection, that's very different than a lateral branch block for the sacrum. And that is something you have to kind of think of when you're doing your algorithm of patients of what type of treatment to do next or when you should send them for possible surgical intervention. So next slide. So it's important to think about physical exam. Most physicians, and probably many of you are well aware of about 5 or 6 major sacroiliac joint exam treatments or provocation signs we look for. And it's pretty common. They'll talk a little bit more, Dennis and Dr. O will talk about the specifics of how many are positive and how many are not positive and what you should do next. But it's important to understand to have a methodology or an algorithm of what part of that joint that exam is truly stressing. So what I've done is I've taken the the names of the most common SI joint exams and put the force vectors, or which part of the SI joint is actually being stressed when you're performing each exam. And that's important to know, because depending on which sign is provocative, it's not just, hey, 3 out of 5 are positive. It's which 3 out of 5 are positive, or which 4 out of 5 or 4 out of 6 exams are positive. That will help guide your thought process of, hey, should this patient be more likely to be a fusion, or should we do some posterior capsule injections or radiofrequency? And that's very important to think of. So for myself, what I do is I usually start with all my patients, I start with the compression exam. And the reason I do that is literally I'm transmitting force to compress the sacroiliac joint together. So if there's wear and tear and arthritis, just like think of it like your knee. Somebody comes in with knee pain, you can do different exams to compress that joint, check the medial or lateral aspects of that joint, or as well as anterior and posterior ligament damage. You have multiple exams. It's the same for the SI joint. So as you start with compression, and if that elicits pain, then I know that that whole joint might be irritated or have significant arthritis in it. Then I usually do the thigh thrust exam, and that kind of transmits direct anterior to posterior force on the sacroiliac joint. After that, then I go to things that involve the rotational, which is the Ganslin's exam. And then I finish with my anterior provocation signs, Faber and distraction. And so what that usually kind of helps me decide is, depending on which one of these exams are positive, if the most provocative physical exams are the beginning and the end of my exams, that's the compression and then the anterior portion, I'm thinking most likely is the joint itself. If it's more the posterior or rotational components, then I think maybe posterior capsule as a target, and you think about going to blocks first rather than intra-articular injection. And the slide I have up there, or the graph I have up there next to that, it's a study that came out in 2013 out of Korea, and what they were looking at is to say, if you move the sacroiliac joint with different physical exams, what part of the joint is that stressing? Does it really make a difference? And the higher the blue bar is, the more stress there is on certain ligaments that are located in the sacroiliac joint. And so it is a compression test, doesn't put as nearly as much stress on the posterior ligaments as, or the anterior ligaments as the distraction test. And that's what's represented in that graph there. So it's not just a theory, it's actually starting to be proven correct that depending on which part of the sacroiliac joint you're stressing, you might be stressing more ligaments or more the joint itself, helps give you a clue of which way to go in your treatment algorithm. Next slide, please. And so, innervation, Roberts, came out in 2014 with an excellent cadaveric study where he looked at, where is this joint being innervated and what do we do? So if you're thinking of doing, people often ask the question, should I do a lateral branch block first or an intra-articular injection? Well, I think if it's more posterior related and in that capsule, you have multiple nerves to hit. And those nerves of that sacral network, Robert's study showed that almost all the specimens had S1 and S2 innervation. A majority had S3, and then a smaller percentage had L5 and S4. So I often do lateral branch blocks first if I think it's more posterior in that capsule. Now there's debate as to which technique do you use. There's the Dreyfus method then in 2009 that talks about the multi-depth method, and then some people just kind of flood the area. I try and be specific, and I follow more the Dreyfus method from 2009 with a multi-directional, multi-depth approach of putting very small anesthetic, because I'm really trying to target just the lateral branches that innervate the sacroiliac joint. And the reason I do that is if I can get a good positive response from those blocks, I can then proceed with radiofrequency ablation to hopefully help cover that. If that doesn't help at all, oftentimes then I'll go ahead and do an intra-articular block for two reasons. One, to see how much challenge it is to get that needle into that joint. If that's a really compressed joint, not a lot of synovial space, that joint's pretty worn and torn, then I'm thinking along the lines of a fusion much higher in the algorithm. And also, if you truly want to get some blocking, some anesthetic in the anterior portion of that joint, the intra-articular ways is the way to go. And again, based off of my physical exam, I'll see if there's some anterior versus posterior distraction forces or pain that guides my decision in that process. And then go ahead and next slide. And so again, I just kind of went over that, the lateral branch block. There you can see some slides there showing the radiofrequency ablation techniques that are done. There's various different ways to do it. You can do a wand approach. You can do individual RF cannulas as well. The intra-articular branch, like I said, if I really want to get anterior, I'll do that. I'll do radiofrequency ablation. Now, depending on the response to those, both blocks, injections, and radiofrequency, often what I do is I repeat those same physical exams right after I do the procedure. If it's a block or local anesthetic, my patients, I don't use much anesthesia, so I don't use any sedation. So it's easy just to get a little local anesthetic. I do the block, and then I repeat those exams and look at my notes before they leave the office that day to see how they responded. And depending on how they respond to my blocks, lets me further know if I'm truly targeting the right area based off their second set of physical exam findings. And the next slide. And oftentimes, you know, you get temporary relief or some relief that works great for a short amount of time. And what do you do next? And those are kind of the things that, you know, Dennis and everybody else is going to talk about next, about using multiple systems we have available to us today to do both posterior fusion approaches and lateral approaches. And I'm really excited to hear what they have to say. So with that, I'll turn it over back to Jessica to introduce the next speaker. Thank you.
Thank you, Dr. Lee. I always, even when we see these reviews that we're all really very well accustomed to, and procedures and exam findings, I always learn something new. So thank you very much. So let's go ahead and move on to Dr. Patterson. He's going to talk to us about the posterior approach to the sacroiliac joint fusion. Dr. Patterson is a board certified pain medicine and physical medicine and rehabilitation physician, and he is also the founder and owner of Nevada Advanced Pain Specialists in Reno, Nevada. Dr. Patterson.
Hey, good evening, everyone. Thanks, Jessica. Hope you guys are all having a good night. Thank you for joining us on tonight's topic. As you can see, there's kind of a brief introduction that Jessica went over above. At the bottom is my disclosures. Probably the one that's relevant to tonight's conversation is that I do some consulting work and speaking for Sacroiliac. Next slide. So tonight, what I'm going to go over is I'm going to talk about SI joint pain prevalence, which Eric's already previously covered. I'm just going to highlight it real quick. I'm going to talk about SI joint pain conservative care measures, and I'm also going to talk about the disadvantages that we've seen in some studies from those treatments. Then I'm going to go over how to identify SI joint fusion candidates within your practice. After that, I'm going to go over some posterior techniques from some commercially available products that we have out there to us. And then at the end, I'm just going to highlight some advantages and disadvantages of the posterior stabilization or SI joint fusion technique. Next slide. So as Eric was saying, you know, in our pain clinics, we're going to see that 20% of patients who walk through our door who have had no previous spinal intervention can have SI joint pain as their #1 cause of lower back pain. In patients who have had spinal interventions or some type of fusion, we see that this number can jump up to 40%, or as Eric was saying, some studies show up to 60% of patients. And that's all due to adjacent segmental disease. If we look at pressures that are put on the SI joint, we see that there's a 60% increase across the SI joints with an L5 S1 fusion. And when a patient has an L4 through S1 fusion, we see that those pressures increase up to 168%. And so the SI joint, since that's the adjacent level below the fusion, it definitely it bears the brunt since it's the next joint that can move. Conservative measures that we've used over time to treat these patients are physical therapy, pain medication, steroid injections, which I'm sure we all do, and then a lot of us do radiofrequency ablations, but that can be limited by insurance coverage nationwide. Next slide. But what we see here is that some of the conservative measures are very limited. And from our orthopedic colleagues in 2007, Vaniklokin, he did a study where he published looking at conventional medical management versus an RFA versus a stabilization or fusion procedure. And what we saw here is that the patients on the VAS, all their numbers are pretty much the same across all boards. Following an SI joint denervation or fusion, we see that the pain drops significantly. But unfortunately, after RFAs, the patient's pain will return. But we see that the VAS is stabilized after a stabilization procedure. And if you track these patients out to 5 years, we see that the stabilization or fusion population has done significantly better than patients who have had a RFA or conventional medical management. In this article, they also have a similar graph showing opioid use. And what's striking to see is that the patients in the conventional medical management and SI joint denervation, 5 years later, 80% of them are on higher doses when they were initially seen 5 years earlier. Another thing to highlight about this is that, you know, a lot of patients, we can do SI joint injections, but they're not a candidate to radiofrequency ablation due to their insurance and their insurance coverages. Next slide. So if looking at patients and whether or not they're an SI joint fusion candidate, I think there are several things that we need to look at. And I pulled this information from the Noridian local coverage determination. So the first thing that we see is that patients have to have 6 months of pain, or a pain history of 6 months, and they have to have failed conservative care. And typically what we're looking at is that they've failed physical therapy and steroid joint injections. What we're also looking at is that the pain is non-radiating, that it's not a radicular pain. They don't have pain shooting down to their foot, and it's more extremity pain than it is lower back pain. As Eric highlighted, we need to see a physical examination that is consistent with SI joint dysfunction. And typically what we're looking at is that 3 out of the 5 physical exam signs need to be positive. And that doesn't include Fortin sign, which is just pain palpation over the SI joint. It's nice to document that, but that's not one of your 5 physical exam signs. So specifically, we're looking for a positive Faber, compression, distraction, thigh thrust, or Gainsland's. And then you want to make sure that your patient doesn't have any other generalized pain disorder that could be contributing to their pain, that it's not a case of somatization or fibromyalgia that's the source of their pain. Those patients aren't going to do well with an SI joint injection. Next, we want to see that they've had 2 SI joint intra-articular injections. And specifically, we want to see that patients got at least 80% pain relief during the local anesthetic with that injection. In patients who don't improve with a steroid, at that point, you can look at being a candidate for moving forward with a stabilization procedure. So here we're going to highlight the posterior technique to do that. Next slide. So here are 3 different allograft products that are commercially available to do this stabilization. Next slide. And I'm just going to walk you through each one individually here in a second. But what do I want to highlight? I want to highlight that doing the posterior SI joint fusion systems are very simple. The approach is very similar to how we do posterior SI joint injections under fluoroscopy. So we're already very familiar with the technique. It's reproducible. It can be done repetitively without having any nuances that we have to get used to. And the other thing is that we got several options out there. We've got options to place 1 implant or 2 implants to stabilize the joint. Some of the products involve a drill, others do not if we don't feel comfortable with using a drill. And so let's walk through these now. Next slide. So here's one of the products that is available. This one is a 2 graft posterior stabilization procedure. The first step, as you'll see here, is in an AP position. We are going to get Steinman pins into the SI joint. From there, we're going to move to a lateral fluoroscopic view and carry out the procedure for the remainder. As you can see, the Steinman pins are in the SI joint. Next slide. Following that, they've got a joint finder that will advance over the top of the Steinman pin. So as you see here, I've kind of highlighted the steps from left to right, but even though I'm doing the top one, the bottom one, it would be sequentially either on the top or the bottom when doing it. So we see the first one is our joint finder goes over the top of the Steinman pin. The next one, we have a working cannula that's going to go over our joint finder, and that's going to give us the working cannula in order to do the procedure. Next slide. The next step is to decorticate to make space for our implant. And in this case, we're going to use a drill. The drill is quick and easy. It takes 2 to 3 seconds. It's got a safety stop to prevent the drill from going too deep. After the drill is done, bottom right, we're looking at the broach. The broach is about a ½ millimeter smaller than our implant. So we get a nice press fit at the end of placing the implant and an immediate stabilization following procedure. Next slide. After the broach is removed, then we're going to put the implant and deploy it into the joint space. And then if you look on the right fluoroscopic view, we'll see two implants that are almost at a 90-degree angle to one another to stabilize the joint. One on the inferior part of the joint and one on the superior part of the joint. Next slide. This is a one graft stabilization procedure. So at this point, we're going to put a Steinman pin using the C-arm and then AP view into the middle of the SI joint. Step two, we're going to do a series of dilators to get access to the joint to place our implant. Next slide. At that point, you can decorticate the joint, which you can either use, in this case, it's going to be a hand drill or box cutter to decorticate the joint. And then at that point, we are going to deploy the allograft joint or implant into the joint space. And at that point, we remove all the equipment. Next slide. This is the third option, and this system can use one or two implants. In this one, I'm going to show you how the upper and lower implant is placed. So we've got a K-wire that goes in the top part of the joint here. From there, we have the joint finder that goes over the top of the K-wire and gets into the SI joint. The next is our working cannula. As you'll see, there's the working cannula goes over the top as a series of dilators. The next step, we either have a hand drill or a box cutter to create or decorticate the joint space and create space for our implant to go in. The next piece of equipment will deploy the implant. And then the last thing is we have a DBM plunger to put DBM down in around the implant. Next slide. Same series for the lower implant. We got the K-wire, followed by the joint finder, followed by the working cannula, followed by the drill or box cutter. And then we've got the inserter to get the implant in, followed by the DBM plunger. Next slide. So several potential advantages of doing a posterior SI joint stabilization procedure is neurovascular safety. In the posterior part, there's not many major vessels or nervous tissue that we have to be aware of with the lateral, like there is with the lateral approach. Using these allograft dowels, we have no hardware, so there's no hardware-related complications. Sometimes when you see stress shielding between metal and bone, that can lead to a pseudoarthrosis. And the next advantage that we see is that patients may be ambulatory post-procedure, that they can walk out of the surgery center and they have no weight-bearing restrictions on the procedure. Next slide. The disadvantage of the posterior approach is that we have very limited data on this. There's no prospective studies. If you click, you'll see that there are several posters, click again, that have been presented at some of our society meetings. These are all retrospective analysis and nothing prospective. But right now, I believe that several of the companies are looking at doing prospective multi-center studies underway. So hopefully that will give us some future insight on how advantageous this approach may be. Next slide. And with that, I'm going to turn it over to Dr. O to talk about the surgical perspective of doing the lateral stabilization or SI joint fusion. Thank you.
Thank you, Dennis. Next up, we have, as Dennis said, Dr. O. Dr. O is a fellowship-trained neurosurgeon, and he's a professor in the Department of Neurological Surgery at the University of California, Irvine School of Medicine. And he's going to give us a breakdown of the lateral approach for sacroiliac joint fusion.
Hello, everyone. So again, my name is Michael. I'm at UCI, but I was previously in Allegheny Health in Pittsburgh. That's where I've done most of these procedures. I have about 200 lateral approaches and some posterior approaches as well under my belt. And I've had follow-up about 5 years personal experience with SI joint fusion. I have no financial disclosures at all. I've been involved in the PI, as a PI for us, the Insight, Sci-Fi, and Lowest studies. Those are all sponsored by SI Bone, but again, I've never taken a dollar from them. I've also used SI Lock, which is Globus, a screw-based one, Rialto, which is Medtronic, one that's an oblique posterior, and Zyga, which is lateral, but also involves decortication of the joint. I'm not going to go over all of the indications again, but I just want to point out a couple things that wasn't highlighted by the previous speakers. One is that the main motion of the joint is something called nutation and counternutation. So it's sort of like clockwise and counterclockwise. And there's not that much motion in a normal patient. In the normal males, from 1 to 2 degrees, females 2 to 4 degrees. And with that variability in male female, you'll see that SI joint pathology shows up twice as many in as much in females as it does in men. I don't think anybody highlighted that, but that showed up in all of the randomized as well as some of the longitudinal studies. So that's one of the other things. As far as the provocative maneuvers that were mentioned, you do have to have 3 out of 5 provocative maneuvers as well as a positive finger forking test. But the positive, the one that is usually the most painful is the Gainsland's test, the one where you hang the leg off the table, and that if they jump off the table with that one, that usually tells you that you've got the right diagnosis. But it really is important to look at the indications and exclusion criteria for the initial studies that got this thing FDA approved, because you know, it's when you start freelancing things and ignoring the initial indications, then you get into a little bit of trouble with poor outcomes. So some of the important things to rule out are hip pathology. So oftentimes these patients have I also get them orthopedic evaluations prior to doing SI fusion. You have to make sure that they don't have a lumbar condition, but lumbar radiculopathy or spondylolisthesis that might be actually causing the pain. And so being a neurosurgeon, I take care of that part of the consultation myself. And then once you isolate to the SI joint, it's important to get those diagnostic injections. I use the NAS criteria, which is not 80%, it's 75%. And you need 1 injection. I usually take the 1 therapeutic and 1 diagnostic as my conclusive evidence of SI joint pathology. So once they've met all of those inclusion criteria, make sure the exclusion criteria are not there. Patient setup is pretty simple. I put them on bed, a flat Jackson table, usually with a beanbag so I can buttress the other side. Make sure that there's a roll under the chest and the hip. Next slide. And the procedure overview, it's fairly straightforward, just as you do with the posterior approach that was demonstrated. You have to have good x-rays. You have to identify that line called the sacroiliac line. That's the one that looks more horizontal on that top left. You have to get the first pin in the right place because that guides next to, there's parallel pin guides. So the first pin is the most important one. Once you have that one in, then you rinse and repeat these steps. You put a soft tissue protector in, you measure the depth, you drill over the pin, you broach over the pin, and then you insert the implant. And then, like I said, you rinse, repeat 2 more times. If you have good x-rays, this can take about 25 minutes. If you don't have great x-rays, up to an hour, but it really should be the whole procedure from skin incision to skin closure less than an hour. Next slide. So again, these are the important views you have to have. On the left is the lateral view, and that white line that's almost horizontal on the bottom, that's the sacroiliac line. I don't have control over an arrow, but if you see that white shadow of a line, that's the sacroiliac line, and you have to be caudal to that line. You see the ventral sacral line, that's the front part of that sacrum. And the SI joint actually goes a decent amount in front of that, so you don't have to worry about being behind it. You have to be actually close to that ventral line. And I'll show you with the implants later on. Next, in the middle is the inlet view. Sorry, go back to the last one. Yes. Yeah, so you have to have a good inlet view that shows you the pelvic rim, and you have to have a good outlet view that shows you the sacroforamina. If you don't have good views, then you have 2 options. One is to call in another rad tech, or to consider doing this under navigation. So you can actually do this with neural navigation or spinal navigation, and that can help in patients where you can't get good fluoroscopic images. Next slide. So again, the first pin placement is important. It has to be below that sacral line on the lateral projection. It has to be above that pelvic brim on the inlet projection, and it has to be above or not headed right towards the sacral foramina on the outlet view. So once you get the lateral pin in, in the lateral view, and you confirm the inlet view, then most of the rest of the advancement is done on the outlet view. And you just keep advancing the pin until it goes across the joint. Next slide. Once it's across the joint, then you go through a sequence of drill, broach, and then pin insert, and then the implant insertion. And then, like I said, you repeat that times 3. Once all 3 are in, then you back it out, inject some flow seal or hemostatic agent, inject some Marcaine, and then close up. Next slide. This is an example of what the final placement would look like on the lateral view. You can see that the caudal 2 implants are past or riding that ventral sacral line. Like I said, the way that the SI joint is shaped is that's perfectly acceptable and actually preferred location for the second implant there. And then again, the inlet view, you got to make sure there's no breaches of the pelvic brim, and then outlet view that there's no impingement on the sacral foramina. Next slide. Some people do use neural monitoring for the procedure. I think if you have good fluoroscopic images, you don't need it. It depends on how litigious an area you work in. Again, my closure, once I get the confirmatory x-rays, inject Marcaine, standard dressing, it's usually about a 2-inch incision or less. Post-op protocol, I keep them 3 weeks of partial weight bearings, up to 6 weeks, depending on how large they are. And then I progress to heel toe gait with normal foot progression. Next slide. So what's the evidence for this SI joint fusion? Most of the evidence is lateral approach, and most of it is with that SI company, SI bone, with their iFuse system. There are 4 prospective studies. I was involved in Insight as well as SciFi. Insight was the randomized control study, and SciFi was the single arm study in the US. There's dozens of retrospective cases, but there hasn't been that much long-term. The most recent long-term study that came out was from the follow-up to the Insight and SciFi studies. That was called LOIS. Next slide. And what this study was presented last year at the IASP meeting, and this is going on to publication. Some of the results from this show that the results that were found on the prospective randomized trials have lasted for 5 years. These results look like this. Next slide. So you see that the visual analog scores, they drop significantly, 4 points at least, for 40 points on a 100-point scale fairly early on, and then drop a little bit more by the time they're 6 months out, and then stays sustained, improved for 5 years. Similarly, when you look at the disability ODI index, it drops, and by 6 months it reaches sort of the bottom, and then it stays down for 5 years. So at least we know we have fairly good evidence that this is enduring for 5 years using this lateral approach. Next slide. As was mentioned by Dr. Patterson, the opioid use declines. I have some issues with this one, is the fact that most of these studies were done at the same time that a lot of the opioid dependence issues were recognized, and opioid use for everybody was decreasing during these 5 years. So I'm not sure if the company gets credit for that, but it did decline during those 5 years. Quality of life index on the left, that improved during the 5 years and stayed improved. Next slide. But for me, the most convincing evidence was not only my own experience with my patients. They were very much like the study results that were published. Somewhere in the 75–80% of patients were very satisfied with the procedure and would have it again. Next slide. But this was what I thought made the studies more honest, is that you could see here, and we all know working with these patients, that if you're out of work, it's hard to get people back to work. And even if you do a successful SI fusion with good improvements in VAS, good improvements in ODI, guess what? You don't get them back to work still. So that part, I thought if they had showed me slides that demonstrated that 80% of patients got back to work, that I wouldn't believe it in any case, no matter if I was part of that study or not. Next slide. I think it's important whenever we talk about any procedures that there are always adverse events. There's, you know, I even with this kind of procedures, I've seen non-unions, I've seen complications related to fracture of the iliac or SI, iliac bone or the sacrum. So in these kind of randomized studies, you record every adverse event, and you can see that in 94 patients, there was a good number of adverse events. Most were not related to the pelvic spine, but there were some. So you have to watch out for things like SI causing more SI joint pain, contralateral SI joint pain, buttock pain and thigh numbness, pelvic floor nerve impingement, hip pain. There were 3 revisions in this group, and out of my personal experience of 200 patients, I've had 2 patients where I had to revise, one for pseudoarthrosis. They just didn't fuse across one, and they thought that because of the lucency around that implant, they had to have it out, and they still didn't get better. And there was another one where my implant trajectory was a little high, and I broke off a little piece of the bone right into the L5 nerve root. Next slide. So the vascular anatomy on the lateral view, you don't have to worry about those big vessels that's in the pelvis. You just have to worry about the small superior gluteal artery. It's usually away from the implants, but you can get a small branch of it. If it bleeds, you just have to cut down further and coagulate it, and it stops. So it's not a big deal, but it can turn your 30-minute operation into an hour operation and make it frustrating. But it's just a small artery, and you just cut down. So you got to watch out for that one. Next slide. The other thing you have to watch out for is this location of the L5 nerve root. It courses over that sacral promontory, and if you get too close to that edge and break off a piece of bone or drive your K-wires too deep, then you can impinge or damage that L5 nerve root, and then they'll end up with an L5 radicular pain after your procedure instead of just their SI pain. Next slide. So in summary, I think that if you stick with the initial indications, watch out for the contraindications, do a standard approach, then you're going to have patients that are very satisfied with your procedure. You're going to have very low adverse events. You're never going to have 0, but you're going to have low adverse events, and you're going to have a procedure that you can do in under an hour that gives them a significant amount of relief, and 80% will come back and thank you. That's me. Thank you.
Thank you, Dr. O. Okay, we're going to switch gears a little bit now and move into the demonstration of the techniques. And again, we're going to have 3 different demonstrations here, 3 different videos. And so what you'll see is the video, and then you'll see the physician who's performing the video kind of talking over it and talking us through it. So we'll get started here with Dr. Amirdelfin, who is one of the founding partners at IPM Medical Group in Walnut Creek, California. He's also the department chair of pain medicine at the John Muir Medical Center in his area, and he performs extensive research and lectures across the globe, and is one of the foremost global key opinion leaders in our space. Take it away, sir.
Good evening, everyone. Thank you so much for that introduction, Jessica. So I'm going to demonstrate the PainTech posterior approach procedure here, which is the link procedure. It's called LINQ. And as you can see, I'm just identifying the SI joint by taking an oblique view of the fluoroscopic guide right there. And you can see the SI joint really well on the left side of this particular specimen. The first thing we'd like to do is we start with the Steinman pen right in the middle third of the sacroiliac joint itself. I use fluoroscopic guidance and follow the beam of the fluoroscope all the way down right into the middle of the SI joint, just like that. You typically take a medial to lateral approach. And the reason for that is it allows for you to be able to fall right in between the sacrum and the ilium without any issues. Once the pin is appropriately placed, I typically tap it right into the joint itself. Once we have engagement and some capture of the pin within the joint, then we can go lateral in order to be able to see the position of the Steinmann pin within the sacroiliac joint itself. The anatomy of the joint was very eloquently explained by Dr. Lee, Dr. O, and Dr. Patterson. And now you can see how we really use this anatomy in order to be able to determine where we are. You can see how my pin is right at the posterior aspect of the sacrum. I'm tapping it in. I want my Steinmann pin to be right in the center of the sacrum itself. And I really like that position right there. It looks really good to me. So once this is done, the incision around the Steinmann pin really does not need to be any wider than the cannula that we want to use to be able to approach the sacroiliac joint itself. So I'm going to introduce the cannula itself onto the field in just a second in order to make my incision. That was the scalpel blade. There's the cannula. I'm putting the cannula down and I'm going to make an incision right inside the skin. The skin was a little bit tough on this specimen, so I struggled with it just a little bit at the beginning. But as I said, the cannula itself is as wide as you need to get with this. And pretty much once the Steinmann pin is in place, everything else will follow the pin itself to get to the sacroiliac joint. The advantage to this particular technique is the fact that it's a posterior approach. There's not a lot of vascular process we need to worry about. But once the skin is inside, you basically take the scalpel blade and take it in and release the ligaments along the Steinmann pin in order to allow facilitation of the dilator and the cannula to go inside. The dilator is then engaged right inside the cannula, and these devices are keyed, so there's only one way to put it. The short step goes towards the sacral side, the long step goes towards the iliac side, and that's how we get started with this whole thing. So you put it right over the Steinmann pin. I'm going to grab my mallet and slowly tap the device right into place. I'm going to take care to follow the orientation of the sacroiliac joint itself because I want the two tongs of my cannula to fall right into the sacroiliac joint itself. And once I start to have capture within the soft tissue, I typically go lateral and I'll follow lateral fluoroscopic guidance to get the tongs of the cannula right into the sacrum itself. As you can see, I'm pushing a little bit more cephalad to get that sacral side of my cannula to seat very well right onto the sacrum. And I'm really happy with that placement. That looks really good to me. A few more taps for posterity. And at this point, you can see how the sacral side is seated. The tongs are in place within the sacrum itself. And the cannula, the dilator can be very easily removed by just twisting it and pulling up. Typically, the Steinmann pin comes right out with it. You can see the Steinmann pin pointing out right inside the dilator itself. With an AP view through the cannula, you can see the sacroiliac joint itself. And that's how I know that I'm actually inside the joint with my cannula and I can proceed with the rest of the procedure. So this is actually a really perfect placement right in the middle third of the sacroiliac joint and the sacroiliac joint through the cannula. The next step is to engage the decorticator. It's coming right up. The decorticator is also keyed, just like that. The decorticator with the new generation of these devices has gotten a little bit wider, which actually allows more surface area and more capture and stabilization of the SI joint itself. Once the decorticator is engaged inside the key, I typically go lateral and start tapping the decorticator in ever so slightly. I'm just showing how that thing is keyed, so there's only one way you can actually put the decorticator in. And once the engagement has taken place, we basically tap it in ever so slightly, get the sacroiliac joint engaged, and take it in. Now, the key to placing the decorticator is that you don't want it to go through the ventral aspect of the sacrum itself. Obviously, you can see the cortex at the ventral aspect, and you want the decorticator to be well within the sacrum itself or the SI joint, but not beyond it. And in this particular specimen, we had perfect placement. We only had a few more millimeters to get it to the very end. And as you can see, the decorticator is very well placed right inside the sacroiliac joint, but not through the joint itself to come out the ventral sacral area. Now it's time to remove the decorticator. This particular brand has a slap hammer in it. So you just basically twist off the handle to create your slap hammer, and you can sort of slightly start pulling it out by slap hammering it up. You need to stabilize the cannula in order to be able to do it. The decorticator itself has a very wide surface area, so sometimes it gets a little stuck, so you need to give it a couple of good pulls like that in order for it to come out. You saw how I stabilized the cannula as I pulled out the decorticator, but sometimes they do get dislodged, so you have to be super careful. I asked the X-ray tech to go lateral again to ensure that the tongs are still within the sacroiliac joint. And you'll see in just a second that they indeed are. I'm just tapping the top portion for a little bit for it to be fully seated before I put in my bone graft. So now that's the deployer. That's a bone graft model right there. Typically, we have some demineralized bone matrix that we put right inside the graft itself. Before we put it right onto the deployer, it has the consistency of toothpaste. Basically, you fill in the cavity of the graft and you put it all around it. And once the deployer is engaged with the graft like that, you pass it right through the cannula in a keyed manner. And once again, use the surgical mallet to slowly tap it right into place. The graft is slowly going into the space that we created with the decorticator, and that's it. So the deployer itself works on tension. Once the graft is placed, you pull the deployer out without any issues, and now the graft is in place. The graft is not radio opaque, so you really can't see it too well, but you can make out the shadow right within the sacroiliac joint. This is a perfect placement. The cannula can then be removed. We typically irrigate and start closure of the soft tissue and onto the skin. You can make out the graft right inside the sacroiliac joint in a lateral view, and in an AP view, you can go back and look in the middle third and actually make out the graft placement within the sacroiliac joint itself. And this is one approach with the posterior approach of sacroiliac joint fusion. Thank you so much.
Thank you, Cass. And we'll move kind of on to the second posterior approach. And that's going to be explained today by Dr. Ramo Naidu, who's an anesthesiologist and pain physician and the medical director of pain management at Marin General Hospital. He also serves as the president-elect for the Pacific Spine and Pain Society. Go ahead, Dr. Naidu.
Thank you so much, Jessica. Good evening, everyone. I'm happy to present to you another one of the posterior sacroiliac joint fusion systems from Omnia Medical. This allows for 1 or 2 implants.
Ramo, could you please unmute yourself?
Sure. So I'm drawing a midline right through the spinous processes from L5 through S3, and then I oblique the C-arm, just like you would for an SI joint injection, to line up the anterior and posterior joint spaces. Then I draw a line here as well. This creates basically the boundaries for where we would insert our guide pin. And then what I'm going to do next is locate the S1 neuroforamen and come across the S1 neuroforamen basically as if I was going through the equator of the S1 neuroforamen. I can make some adjustments as far as cephalocaudal tilt as I get there, but this allows me at least a starting point, and I usually start with a 2.5 centimeter incision, which is going to allow the placement of the cannula. So here's the guide pin. I'm entering into the SI joint itself, and I'm malleting in. This should go in fairly easily, and I think you can all appreciate that it is going in easily. So we'll just take some fluoroscopic shots again, just to ensure we're staying within the joint. And again, you're feeling as you go along, just to ensure you're not going into sacrum or ilium. And if you're doing this in a 90-year-old or 95-year-old, sometimes it's hard to tell the difference. So in this particular cadaver, it was very easy to tell the difference between cortex and joint. And as you can see here now, what I've done is made some adjustments for the guide pin to be parallel to the superior end plate of S1. Now what I have here is the joint finder. So this goes right over the guide pin, and basically everything is now going to follow the guide pin. One of the important parts of this step is really rotating the joint finder as you go through the ligaments that Eric and Dennis talked about. So you do some malleting here, just check some fluoroscopic images just to see where you are compared to the ilium as well as the sacrum. And as you can see in this particular cadaver, the ligaments were relatively strong, or maybe I'm weak, but it took a few mallets to get to where we needed it to. Once you get into the joint finder, as the name implies, really does find its way appropriately, and it follows the guide pin quite easily. So what we're trying to do here is basically bring it to about the 50 to 60% aspect of the anterior and posterior sacral plates. And then what I'll do here is I'll place the working cannula, and it is keyed, so there is a side to it. You can see it reads ilium on the right side as we're working on the right SI joint. And then I mallet the working cannula down, and we take some fluoroscopic images just to ensure where our depth is. What we're really looking for is that the distal 1 inch or so, the working cannula, basically abuts the posterior plate of the sacrum, so there's really no lucency going through. So we're getting a little bit closer, and what I'm feeling here is just to make sure that the working cannula is being grabbed by the SI joint itself. So at this point, I'm feeling quite confident that there's decent purchase. Sometimes this will manually come out as far as the joint finder and guide pin or K-wire. Sometimes it takes a few mallet taps just to get everything out. And then what we can do is add a screw pin to the joint finder and then either slap hammer it out or just do a couple taps with the mallet to get it out. And that's what we're doing here. So this is just do it gently, just so you make sure that you don't spray too much blood everywhere. And that comes out quite easily. And then sometimes the K-wire can be stuck, and if you need to, put a hemostat or needle driver and then mallet that out. But that came out fairly easily in this situation. Looking at the cannula there's still a lucency, which we pointed out here. So I did mallet it down just a little bit further just to make sure that lucency was removed as we got to the posterior sacral plates. And that looks good there. And now we drill, and what we're basically doing is creating a pilot hole for the box cutter. So we use our power instrument here, which basically is optional, frankly, depending on how your technique is, but it's nice to have the drill, create that pilot hole. And now what we're doing is we're going to make that round hole into a square hole, because this is going to allow the allograft. So this is the box cutter, and it is keyed. It has an orientation, which I'm pointing out here. And that goes to the working cannula just with that particular orientation. Either it slides down, but usually it requires a little bit of pressure and malleting because, again, you're putting a square peg into a round hole. And that's all dependent on the cortex of the particular bones for that particular patient. So you can see here I've malleted through, take a fluoroscopic shot just to see where we are, and everything looks very good there. I'll slap hammer this out or slap mallet it out. And now I will use a little bit of demineralized bone matrix. The importance of this basically demineralized cadaveric bone here is to promote bone healing and growth after this procedure. So the allograft is basically the spacer within the joint. The DBM is there to help create a matrix for healing to occur over time. So half of it gets deposited anteriorly here. And then here's my allograft. And in this particular situation, we used a fake one, and we put in ball bearings so you, the audience, could see the orientation of the allograft as it goes in. So you can see there the ball bearings. In general, that would be a hollow slot where you can put in more DBM, again, to coax bone growth through the allograft itself. This is a keyed instrument as well, and as you can see there, and that goes in with the inserter through the cannula. Again, we mallet it all the way down to the end of the cannula because we have that perfectly situated. And then we unscrew the inserter. What that's going to do is release the tangs off the allograft so that they sit right where you want them to. And you can see the ball bearings here and how they're oriented. So we have a very nice view. Without the ball bearings, you really wouldn't be able to see the allograft well. So we put those in just to give you guys, again, a glimpse of what it looks like when it's in situ. So the inserter comes out, and then we also add a little bit more DBM on the posterior aspect of the working channel we've created, because obviously we want everything to heal over that as well. And then we use what's called the plunger. I personally call it the honey stick because that's what it reminds me of. Place that all the way down, put pressure, and then take out the cannula and the plunger at the same time, and voila, we're done. As Kaz mentioned, I can use irrigation and then suture with 3/0 Vicryl, 2/0 Vicryl, depending on what you want to choose, steri strips, Dermabond, whatever else, and then we're done. Thank you.
Thank you. Okay, and last but not least, we'll go back to Dr. Patterson, who will explain the corner lock posterior approach fusion. And following that, we'll move on to question and answers. So if you have questions, make sure to drop them into the questions so that we can get to them afterwards. Dr. Patterson.
Hey, thank you, Jessica. So I'm going to walk you through my video here.
Dennis, can you unmute?
So I've put an outline or drawn a line across the SI joint. I'm doing the left side here. What you see now is I'm making incision sites. I want one to be a centimeter inferior and a centimeter superior, but both are about a centimeter medial to the joint. So we're going to make our incisions there. After these incisions done, I'm going to take Steinmann pins and access the joint inferiorly. And usually you can just feel it fall into the joint. Once it falls into the joint, we'll use a surgical hammer just to advance it just a touch. You don't want to advance it, basically get it started, but you're going to do all the advancements in a lateral view. From there you see I'm feeling the PSIS. I want the Steinmann pin to kind of touch the back part of that PSIS. And then I want it to fall inferiorly underneath it and fall right into the joint. Once I get it into the joint, I'll advance it just a little bit to get it started. Don't want to advance it really in the AP view. From there, I will go to a lateral position and advance the Steinmann pins. And what I want to highlight here with this two graph system is you want the graphs almost to be at like a 70 to 90 degree to one another. The next one is our joint finder or T-handle. It's got a safety feature of which, it's got to really enter the Steinmann pin on it, and I have full control. So the Steinmann pin can't move with inside that T-handle or joint finder. It's got a high side and a low side. The low side is going to go up against the sacrum. The high side is going to articulate up against the ilium. So you want to make sure that it's oriented correctly. And then in that lateral fluoroscopic view, once again, we're going to advance the T-handle. And what you want to do is you want to take snapshots fluoroscopically. But what you should feel is that once you contact the sacrum, there's going to be a different intonation or sound or feel as the T-handle advances. At that point, we're going to take the T-handle off. And now we've got our working cannula or retraction guide tube. From there, there's a high side and a low side. Once again, we want the high side to go up against the ilium, the low side to articulate against the sacrum. And now we're going to advance that in that lateral position over the top of that joint finder and have it articulate against the posterior aspect of the joint. Once again, you should hear a change in intonation and feel. So it should sound differently as you start to get the teeth into the joint and the sacrum. Once that is done, the T-handle or joint finder plus the Steinmann pin should be able to pull out easily. Every once in a while, the Steinmann pin will get stuck and a hemostat can remove it. From there, we're going to take our drill to decorticate the joint space to allow bone marrow to access our graft site. As you can see, there's a safety stop on the drill. I usually do this in live fluoroscopic view. And so you'll see it's a quick 2-3 second procedure. Advances down, it'll stop, and at that point we'll back it out. At that point, we've got a keyed broach. We want that to go across the joint space in an orthogonal manner. that'll allow the graft, once placed, both sides of the graft to have access to the ilium and the sacrum to solidify the joint. The broach is about 0.5 millimeters smaller than the actual graft itself. So once we deploy the graft, we should have instant stability. At this point, we're going to use a slap hammer to get the broach out. It's pretty pressed in there. At this point, I want to highlight that you want to make sure you hold on to your working cannula, because as you slap hammer it out, you don't want that to get dislodged. That's in the joint space. From there, we're going to deploy our DBM sponge, and once again, that's keyed with the instrumentation to put it right where we need it. The DBM sponge is going to act as scaffolding to promote our bone fusion as the graft takes place over a 6 to 12 month period of time. Now, as our graft, like we were saying, we want this to be placed orthogonally across the joint, so it's keyed as well. Since it's a little bit bigger than the broach, it takes a little bit of a hammering to get it into place. At that point, then you can use the deployer to get it out. And as you'll see in the practicing, we've got a screw, or sorry, a nail in the graft, so you can see it on fluoroscopic guidance, but typically it's kind of like Kaz's, that you can just see a shadow or an outline. Now we're going to do or repeat the exact same steps on to place the superior implant. So once again, we're going to use our T-handle. We're going to advance this in a lateral fluoroscopic view. There's the high side and low side. Low side is going to go up against the sacrum. Once it starts to make contact with the sacrum, you're going to the pitch as we advance it in the feel are going to feel different. We want to get those teeth down into the joint. Once again, we're going to take a retraction guide tube or our working cannula and go over the top. We want to orientate it so the high sides to the ilium, the low sides to the sacrum. Again, we're going to use our surgical mallet to advance this. Once we access the sacrum, it should feel different and sound different, and that's where we know that we've almost reached our endpoint. At that point, we'll pull it out. As you can see here, this will be one of those examples that our joint finder will come out, but our Steinman pin will not. And as you can see, just taking a hemostat and grabbing it, it'll come out pretty easy. Once again, there's our drill. As you can see, there's a safety stop. It's a quick 2 to 3 seconds to decorticate the joint space to get access to the bone marrow to help with the healing process. At that point, we've got our broach, which once again is going to be keyed because we want to go orthogonally across the joint space. Since it's going to be a tight fit, we're going to hammer that down. And then we're going to take the slap hammer once again to take that out. And as I said, you don't want your working cannula to be dislodged out of the joint space. You want to make sure you hold on to that tightly as you slap hammer the broach out of the joint space. Once again, we're going to load up our DBM sponge and our deployer, which again is going to act as the scaffolding to allow our fusion to take place over the next 6 to 12 months. That is keyed as well. Once we get that into our graft site, we will deploy it. Then we will load up our graft. Maybe tough for you to see, but the graft's got ridges on it, so it makes it sure that it can't come dislodged or migrate posteriorly. As I said, the graft is about 0.5 millimeter bigger than the broach, so you have to hammer it down in. Then you use the deployer once again to get the graft loose. And at that point, you would pull everything out and get a final AP and lateral image of your graft. that's essentially it.
Thank you, Dr. Patterson. At this point, if we can get our panelists to all come back on here, we will go ahead and start our question and answer session. We've got some great questions from the audience. And so we'll just sort of dive right in here. And I think, Dr. Lee, let's start with you. We've got an audience member who's asked the question about the SI joint lateral branch block, whether or not there's this is a procedure that's covered by health insurance, and if so, is there a specific code for this?
Yeah, that's an excellent question. The way I end up doing reimbursements, its own entity, and obviously different insurances handle things differently. But in general, what I do is I do the lateral branch blocks and bill it as a peripheral nerve block. Is pretty much how I end up billing most of mine. The goal for that is it's a diagnostic procedure to give you good evidence of what you should do next. And so for that, I just think it's simple and clean just to do it that way. Some people, if they're including the dorsal primary MRI of the L5, we'll kind of have a medial branch block for that L5 portion. But for me, I pretty much focus on the peripheral nerve blocks and just list the levels I did, S1, S2, and S3, and just do that, times 3 or 4, however many levels I did.
Can I chime in there real quick? I'm sorry.
Of course.
I just want to point out for 2020, they actually developed a specific code for the lateral branch blocks, 64451. Which is a change from what it was before with peripheral nerve only 64450. So that's a brand new CPT code specific to the lateral branches.
Well, there you go.
Perfect.
I didn't know that either. That's great. Thanks, Rama.
Sure.
So excellent there. Cass, let's move on to you. I've got a question coming in about some complications, and then followed by whether or not SI joint, you've done SI joint fusions bilaterally at the same time. So the first question is, have you encountered bleeding issues during your implants? And if so, how are those managed? Or other potential things that kind of, those 3 videos were pretty textbook. So talk to us about sometimes when it's been a little frustrating and what that consisted of, as well as that bilateral question.
Sure. So first of all, those videos were textbooks because that particular specimen wasn't bleeding. So bleeding does happen. We're decorticating bone, so you can see bleeding. But the important thing is not to panic. First of all, you have to make sure that your patient is off of anticoagulants. They're not taking any aspirin or anything like that. That could potentially potentiate the risk of bleeding in the patient. Once all these comorbidity factors have been ruled out, and when you engage the patient, sometimes there is bleeding, but usually it stops with just the pressure that you're putting in with the graft itself and with the closure. From time to time, you may have to put some gel foam in there for you to stop the bleeding, but it's never been so complicated to the point that it can't be done. So as long as you don't panic and as long as you have a plan, it can be done. From a bilateral standpoint, if you have indeed proven from the provocative test and from at least 2 injections to show that the patient can have significant pain relief in those areas, then you can indeed do a bilateral sacroiliac joint on the same day without any issues.
Okay. Dr. O, we've got a question here. We're going to try to wrap up in the next few minutes here, but the question is regarding your NAS criteria with 75% relief, and you mentioned 1 injection that's diagnostic and 1 that's therapeutic. And the audience member has a question. When you're talking about a diagnostic block, can you include steroid in a diagnostic block?
Yeah, well, usually the first time I send them with a diagnostic followed by along with the steroid. So I ask them for the steroid injection, but I have them record the first 4 hours of their pain relief because there's a local in there too. So I usually work with a few pain physicians, interventionists that do the same protocols. And so that, because they use local at the beginning, they document it, I use that as one of the 2 diagnostic tests.
Excellent.
And the final question I'll direct to you, Dr. Patterson, and then we'll wrap it up, is we talked a little bit about the fact that patients can weight bear. After they've healed from this, do you see limitations on any sort of ability? So specifically, if you have a patient who wants to ride horses again, are they going to be able to ride horses or do these sort of really active things that kind of stress the pelvis in the future?
Yeah, so that's an excellent question. So following the procedure, I'll let my patients, do their normal activities of daily living. I'll let them ambulate. I'll let them, dress themselves, feed themselves. I still want them doing high impact activities, probably for at least the first 6 to 8 weeks. And so that would mean running, jumping, those are the type of activities that I want them to avoid, so I can allow that fusion to take place and hopefully settle in over that 6 to 8 week period of time and hopefully fuse the joint. Initially, we want the pro-inflammatory stage to take place, where we get the mesenchymal cells there from the blood flow that we've created by the decortication to allow those cells to bone formation. And if we have any pounding or shearing forces or anything else going on, that may influence those cells to form soft tissue instead of bone. And so I think we want to be careful on what type of activities patients are doing immediately following that. But I would say after a 6 to 8 week period of time, there'd be no problem with getting back to, running, jumping, or riding your horse.
Excellent.
Just
And
a quick
with that,
comment on that. Sorry to interrupt. But yeah, I think that's the key distinction, right? Dr. O's lateral approach, you're putting in hardware. That's the stabilizing graft itself versus the posterior approach, as Dennis mentioned, it's trying to grow in there with that deep mineralized bone matrix that takes a little bit more time to secure itself. Sure. So that's just important to kind of make that differentiation.
Excellent. Thank you very much. And with that, we're going to wrap it up tonight. Thank you so much to our phenomenal faculty for all of their expertise. If you want CME credit for this, you've got 48 hours to claim it live, and those who are going to be listening to this afterwards can also claim this as well. So again, thank you and have a wonderful evening.
Thank you, Jessica. Good night.
Good night. Thank you.
Thank you.